Good morning, everybody. It's a pleasure being here. Thank you very much for the invitation. So my talk is on patients who experience a ischemic stroke while they are on oral anticoagulation. My disclosures are public and non-profit funding. So when we think about types of anticoagulation, historically the first one out there was heparin, almost 100 years ago, found and used. And 50 years ago, roundabout, it was then the vitamin K antagonists and warfarin acting on several different factors of the coagulation cascade. Nowadays, much more common in clinical practice are the DOACs, namely factor 10 and factor 2, so thrombin inhibitors. More specific and only acting on one factor of the coagulation cascade. On the horizon, we already have factor 11 inhibition, different types, whether it's antisense, antibodies or small molecules. You know that atzaléatimib, for example, had a signal of increased safety with those types of drugs, so I think there's going to be a lot around, but they're not yet in clinical practice. To illustrate you the importance of this topic, I brought you this case. So it's a 53-year-old male. He has AF, so he takes rivaroxaban 20 milligrams at 7 in the morning after getting up, but unfortunately 20 minutes later he develops severe aphasia, and 2 hours later at 9 a.m. he is at our ED door. He has an M3, M4 occlusion on the left side with a mismatch. You can see here his MRI, so he has a profound perfusion deficit, only a small diffusion lesion, and his rivaroxaban level, which we measure always, is above 200. So you can ask yourself, how would have I treated this patient? Would I have said, okay, best medical treatment, stroke unit? Would I have considered thrombolysis, but only after reversal with andexanet or without andexanet? Or just say, don't take the risk of thrombolysis, go for distal empty, although it is not evidence-based either. You can see here how my Twitter bubble reacts to this. And actually, you can see that they're completely undecided and all options seem reasonable. Why is this a problem? You can see here the projections of patients with AF in the European Union. I'm quite sure in Canada and the United States it will be similar. You can see that AF is already a very, very common disease affecting a lot of the population, but the prognosis is that until 2050, the cases are actually going to double due to the increased age of the population. So there's a lot of patients with atrial fibrillation is going to be around, and this means that also a lot of patients with anticoagulation on board will be around. The industry has already noticed this, and there's a huge economic interest also in the anticoagulation market, which is going to rise. Actually, Espen and his team from Norway have analyzed what are the reasons for not giving thrombolysis in patients presenting early who were actually eligible for IVT otherwise. And the vast majority, if you only look at the absolute contraindications, it was only or almost exclusively anticoagulation, and this nowadays is DOAC. I can show you the data from our center. You can see in the blue line up, it's the patients without anticoagulation. They're getting less, and we are already at above 20% of patients at onset who have anticoagulation on board. The orange line is the DOAC line, so they were starting to increase. The gray line falling down is the VKAs, and the yellow one is heparin, so only very rare and special cases. You might say, yes, but how about those actually qualifying for thrombolysis? I restricted this to the early time window and NHSS of at least 4 points. You can see that even more patients are on anticoagulation, around 30%, and there's even a higher proportion of patients on DOAC approaching or exceeding 20% in the last years. Remember, the best is yet to come, so it's going to be a lot of anticoagulation around, and it's going to be very uncomfortable. The problem we have is that the current guideline from the European Stroke Organization says that in patients who took any dose of any DOAC within the last 48 hours, they should not be given intravenous thrombolysis, but the quality of evidence this is based is very low. A problem I see here is that they don't differentiate between the doses. So even accelerelto-vascular, so low dose 2.5 milligrams of rivaroxaban taking 47 hours ago, would then disqualify this patient from intravenous thrombolysis. If you look at the international guidelines, the American Heart Association is very similar, also 48 hours cutoff. And if you look at other guidelines, for example, the Japanese, it's interesting that they are much more liberal. So if DOAC intake was more than 4 hours ago in INR 1.7 or less, you could actually consider IVT. We all know they use a reduced dose, but they are much more liberal and have not made any bad experience with this approach. We once looked in Switzerland in those patients who would qualify for IVT, so early time window, NHSS of 4 or more. If you don't have anticoagulation, you get thrombolysis in 74% of cases. If you have VKA, an INR of less than 1.8, you get 63. And if you have DOAC, you only get 15. So it's a huge barrier to DOAC, to IVT implementation. And the reasons you can see here, even in high-income countries, you don't have the plasma levels available, you don't have reversal available, the plasma levels take too long, or people are unsure which cutoff to use for IVT decisions. And this is the reason why DOAC patients are virtually excluded from IVT. It has been suggested that for dose on dabigatran, we should use Praxbind or either rokizumab to reverse it, and certainly the data is very reassuring, so there is no increased risk of bleeding if you use Praxbind in DOAC patients as compared to controls without anticoagulation. There is no signal for early death in those patients, and you can apply this approach and only delay IVT administration by a couple of minutes. So it's fast, it's feasible, but it's also expensive. The reversal costs obviously some money and is not available at many centers worldwide. However, the main question is, can we apply IVT in those patients without reversal? This was a meta-analysis that came out in 2019. It was restricted to patients with a DOAC intake within 48 hours, no reversal, and they found no increased risk of bleeding, but it is a highly selected population. Then more recently, from the Get With The guidelines, it came out this JAMA publication that found that NOAC intake and was not associated with bleeding increase in patients receiving IVT. Problem was that DOAC intake was defined as within the last 7 days, and we all know that if you took your last pill 6 days ago, pharmacologically there's nothing left, so that's not really the interesting patients. They did a subgroup of those within 48 hours, but the numbers were very low. The bleeding risk, though, very comparable to what we expect. The reason of this missing data, and especially for those in the early time window after intake, was our driving force to gather this international collaboration, where we approached over 60 centers worldwide. We gathered over 800 patients who really took their DOAC within the last 48 hours. We compared them to over 30,000 controls that did not have anticoagulation, and we looked at whether there was increased risk of bleeding after IVT in those. The baseline table, I suggest you read the publication. You just need to believe me that all the baseline characteristics were in disfavor of the DOAC groups. Obviously, they mostly had AF, so they were older, they had more severe stroke, they were treated later. So all this means that they should have an increased risk of bleeding as compared to the controls. However, the risk of bleeding was actually lowest in the DOAC users after IVT, and this was true whether they were offered IVT based on plasma level measurements, based on reversal, or based on neither of the strategies. I can show you the 24-hour MRI of the patient I showed you before. After IVT only, we did not go for distal empty, and you can see that he developed a small parietal and temporal infarction. The aphasia was better. There were no hemorrhagic complications, and the perfusion deficit has gone. The reason we do this is that we believe our observational data, and we have changed our internal workflow. You think this is cowboy behavior? Maybe, but it's also backed up actually not only by observational, preclinical, but also randomized data. Let me show you this analysis, which is the ARISE trial. What did they test? Patients qualifying for intravenous thrombolysis were given, in addition, argatroban. Argatroban is very similar, a thrombin inhibitor, to dabigatran, and they used this at a dose that corresponds to about half the dose we would use for HIT, So HIT, heparin-induced thrombocytopenia, we would use argatroban for anticoagulation, and the dose they used was about half full anticoagulation, and that corresponds pretty well to what we see with the DOAC levels in patients taking DOAC. There was no benefit in terms of functional outcome. There was a neutral trial. However, if you look at the hemorrhagic complications, they were not increased in the patients with argatroban in addition to IVT. So you can say thrombin inhibition, no better functional outcome, but no increased harm. Recently, the MOST trial, which also tested argatroban, however, 3 times the dose that was used in ARISE, was stopped for futility, but there was no signal for harm according to the PIs, even with this higher dose of argatroban in addition to intravenous thrombolysis. So randomized evidence reassuring us that thrombin inhibition is no problem in combination with IVT. This is our proposal, so you should certainly check in at exclusion criteria. I mean, if there's endocarditis, no IVT, and if we have a better alternative, such as a proximal large vessel occlusion, where we can go for direct MT, but it should be available quickly. I'm not talking about transfer patients that you need to send 3 hours to receive thrombectomy. I'm talking about patients where thrombectomy is readily available. Then maybe we don't need to take the risk. For IVT, we can proceed with direct MT. And for those on dabigatran, reversal is obviously recommended by the guidelines and certainly reasonable if it is readily available. And for all the other patients, and probably most of them, as usual in medicine, I think we should do an individualized risk-benefit analysis. I think an expected benefit is a small infarct core, no increased risk of bleeding based on other calculations. But if you have a borderline indication, maybe a proximal M2 or something, then it's maybe better to withhold IVT. And I think one important aspect is to capture all those patients in prospective registries, and trials data is also needed. I know cardiology probably gives us a lot of headache in the daily work. However, sometimes they're also very smart, because in their guideline on thrombolysis for pulmonary embolism and acute myocardial infarction, they only listed oral anticoagulation as a relative contraindication, which I think would be also reasonable in our field. Let me briefly talk about other types of anticoagulation. So vitamin K antagonists, this is old data and the data we always refer to with this INR cutoff of 1.7. You can see that starting at an INR of 1.7, there seems to be a slight increased risk of symptomatic hemorrhage after IVT. However, it's mostly the confidence interval that widens, and we don't have the certainty. But we have to say that with vitamin K antagonists, we do have an increased risk of bleeding, for example, in preclinical models. Some courageous people out there say that for those above 1.7, we should use PCC to reverse the anticoagulation and then proceed with IVT. This approach was feasible in the study without causing huge delays and without a lot of hemorrhagic complications. But as I said, in experimental stroke, there were increased risk of hemorrhagic complications in mice pretreated with vitamin K antagonists. This cutoff is firmly established, and I think in individual cases, yes, we might consider PCC reversal, but it is a questionable approach. It's also mentioned in the guidelines that there's the risk of thrombotic complications potentially. What about heparin? The mode of action, so low molecular weight heparin, mostly factor 10 inhibition, unfractured heparin, also factor 2, but both have also some effects on other factors, which might then be different situation as compared to the DOAC 10A inhibitors. What can we use to establish the activity cutoff to offer IVT? For unfractured heparin, the guideline recommends APTT of less than 40. There was another Delphi consensus that proposed a cutoff of 50, or we can measure 10A activity. For low molecular weight heparin, we should use the 10A activity, and the cutoff is probably an analogy to what we use for DOACs. The reversal should be, if considered, should be protamine sulfate in the case of unfractured heparin, and for low molecular weight heparin, pharmacologically, actually andexanet would work better, but if you don't have it available, protamine sulfate can be offered. The thing is about heparins, I think those are very special patients because usually they are post-cardiac surgery and they have other contraindications to IVT in most cases, and I showed you before, they're very rare, and then they're also very special on the ICU, other problems. So I don't think, the patients on heparin are the biggest problem. However, you can use this flow chart, which is very similar to what we propose for DOACs. So if you have a direct MT option, you should go for it. It has to be said that prophylactic heparin is no problem at all. It's just about the therapeutic dose. The last type of anticoagulation is factor XI inhibitors. I mentioned that they are already on the horizon. I tried to find something because Ashkan told me that there is a paper on rabbits getting IVT on factor XI inhibitors. I was unable to find this paper, so the data suggests there is no data, but I think we should already make up our mind. What are we going to do once they are on the market? Are we going to put them, so new drug, are we going to put them as a absolute contraindications, our guideline, and then struggle to overcome and repeat? Or are we going to handle this differently? I come to my conclusions. So anticoagulation is by far the most frequent contraindication for IVT. The number of patients with anticoagulation on board, and at this time it's mostly DOAC, will increase considerably. Remember, cases are going to double until 2050. I think use of IVT in patients with DOAC needs an individualized approach. If you have better alternatives, go for direct MT, but especially for the eloquent distal or perforator occlusions, consider IVT. In my opinion, the future studies should clarify whether we actually need a reversal before safely applying IVT, or whether we need a selection based on plasma levels, or whether this is all unnecessary and just causing costs and delays, and we can give IVT anyway in those patients. Until we have this evidence, we should use Praxbind wherever available, but we shouldn't delay treatment to send a patient for Praxbind. For vitamin K antagonists, INR cutoff of 1.7 is firmly established. I think beyond that cutoff, you can consider reversal in very individual cases. For heparin, there's no contraindication with prophylactic dose. For the others, I showed you the cutoffs, and you can also consider reversal in individual cases. Factor XI inhibition, no data, no problem, but I think we need to make up our mind how we're going to handle this. And with this, again, many thanks for the invitation, and looking forward to the discussion.
Thank you, Dr. Meinl, for this exciting and very comprehensive overview. We're going now to move to our next speaker. I would like to invite our audience to send their questions on the Q&A on the app. My name is Georgios Tsivgoulis. I'm a vascular neurologist from Athens, Greece. Our next speaker is Christian Nolte from Charité Berlin. He's well known on the research topic that he's going to discuss with us, patients with advanced imaging markers of cerebral small vessel disease. Christian, the floor is yours.
Thank you. Dear Dr. Chairman, dear colleagues, it's a great pleasure to be here. Welcome you all to Toronto. Here are my disclosures. So, first of all, we have to define, of course, what we are talking about, because that's not so easy when we say small vessel disease, but it has various meanings in clinical research, neuroimaging, and neuropathological aspects. Simply speaking, it's any pathological process damaging small vessels, small end arteries, arterioles, venules, brain capillaries. And it's very interesting because the clinical symptoms, as you all know, can be overt, so easily seen, or clinically silent or covert. Many of you know that there are incidental findings on MRI scans when you do MRI scans in patients. Also, presentation can be different. It can be slowly progressive, leading to cognitive decline, mood disorders, or gait problems, or it can be abruptly evolving, like in lacunar stroke, which affects eloquent areas, or, very important, also ICH. So is it of relevance at all? Yes, of course it's of relevance. We all know that stroke patients have a higher burden of small vessel disease compared to the general population. We know that it is an independent risk factor for post-stroke outcomes, especially for stroke, dementia, and death. So it's worth thinking about small vessel disease in various aspects. And what are the neuroimaging markers? I showed you this nice picture of Marco Pasi and Charlotte Cordonnier, which gives you the 4 classical images of the lacunar stroke. The picture also depicts an old ICH of white matter hyperintensities, which could be further differentiated in location, perivascular spaces, or as we say in German, Virchow-Robinsche Räume, to commemorate good old Virchow. And the cerebral microbeads. This picture also shows you an ICH with a star. So there are different aspects, different ways to image small vessel disease, but there's also a global score that has been proposed for practical reasons to make it easier to deal with it. And the question is, does a global score make sense? Is it like in the Three Musketeers, one for all and all for one? We have actually looked into this matter in a huge cohort of 661st ever ischemic stroke patients. And we found, first of all, frequency differs quite a lot, with 1 in 2 patients having white matter hyperintensities, only 1 in 3 having perivascular spaces, only 1 in 10 having cerebral microbeads, and only about 1 in 7 having lacunes. We also then looked what would predict outcome. Would the total score be better or the individual scores? And this heat map shows you the associations to different outcomes, which are depicted on the bottom line: clinical cognitive score, executive function, memory, language attention, modified ranking score, and so on. And the stronger the color, the stronger the association, and the more stars, the higher the level of significance. So what's the result? Of course, there is an association with all these outcomes with a total score, with small vessel disease, as it might have been depicted in a CT scan, for example. But if you look at the individual markers, the individual neuroimaging markers, like the lacune count, the degree of white matter hyperintensities, the CMB count, or the PVS grade, you have a difference between the different markers, with lacune count having the strongest association and the highest level of significance, with a clear dose response, and with CMB actually having the weakest associations with all these outcomes after 6 and 12 months. And what is more, considering the individual small vessel disease markers and their severity led to a better calibration and discrimination of all the predictive models. So I strongly argue that if you have the chance to look into the details, look into the details, because frequency and impact differ. We all know, of course, that we have a dilemma, because small vessel disease, and in this case, Stephanie Debet looked at white matter hyperintensity burden, does not only carry a risk for stroke, but for ischemic stroke and for ICH. And if you just look at the point estimate, the risk for ICH has even a higher point estimate, which is also true for CMB presence. So, like so often, we have to balance the risk and benefits, and we have to balance risk for ischemic consequences and hemorrhagic consequences. And as we have a Greek chairman, I put a picture of Ulysses into this, because there's a classic dilemma, like Ulysses on his voyage, steering his ship between the monster, Scylla, and the strudel, Charybdis. And it's difficult to know whether we go further right or further left to steer our vessel through. Especially, of course, in the case of intravenous thrombolysis, because as we all know, this carries a risk for intracranial bleed. From my point of view, the best meta-analysis to answer this question, CT-based, is still the one of Andreas Charidimou, which I brought here, which shows you this nice forest plot, looking just at patients with IVT, CT-based. That's why it's called leukoariosis. And clearly showing that leukoariosis in IVT patients increases the risk for symptomatic intracranial hemorrhage, with a higher point estimate for severe leukoariosis as compared to the point estimates of any leukoariosis. So there might be a dose response. He also looked at just patients treated with IVT and whether leukoariosis would have any impact of prognosis. And as you can see in the forest plot, yes, of course, leukoariosis has an impact of prognosis in patients that were treated with IVT, and it carries the risk of worse prognosis. So no doubt about it, leukoariosis is not something you want to have. But what we are always talking about is risk-benefit, isn't it? you can't have the cake and eat it too. You have to know whether you're going for it because the risk is lower, the benefit will be bigger. And Andreas also did analysis on the RCTs, which were available at that time, CT-based, in his analysis, and showed nicely that IVT in comparison to placebo, as is shown in the top forest plot, concurs a higher risk for bleeding, but, and that is very important, a lower risk for poor outcome. That's the way he put it, or meaning IVT means you will have net clinical benefit even if leukoariosis is present. Of course, you would want patients which have MRI imaging, of course, and we do have patients with MRI imaging to look at these individual markers because we have the wake-up trial. In the wake-up trial, as you all know, every patient had an MRI scan before decision was made on treatment or whether he was entered into the trial. So we do have data on white matter hyperintensities and IVT in the secondary analysis of the wake-up trial, which was just published this year. And this is a very nice picture of the predicted probabilities. So on the left side, picture A, you see that patients that were treated with RTPA, turquoise or blue, have a higher chance or higher predicted probability to achieve excellent outcome, even if this goes down with white matter hyperintensity severity. But very important, there's no interaction. So it's not the driver. White matter hyperintensity is not the driver to achieve good outcome or not. Very similarly, with the respect of hemorrhagic transformation, there's a higher chance for hemorrhagic transformation, but there's no interaction over the whole range. So white matter hyperintensity does not tell you not to do IVT. There's no significant treatment effect. This picture is maybe easier to interpret, comparing patients with mild to moderate white matter hyperintensities to severe white matter hyperintensities, and the point estimate and the benefit of IVT to achieve an excellent outcome was even higher. Again, there was no interaction, so from the data we have here, severity was not the driver in terms of benefit of RTPA. Lacunes, very interesting topic. You all know for decades there has been a long discussion on whether IVT would work in lacunes at all, because many people believe that we don't have thromboembolic events in lacunes, so why would a thrombolytic then work if it's not a thromboembolic event? There's a lot of CT-based data from the previous RCTs, but CT-based means that we do not have such an excellent definition of lacune, and the final diagnosis of lacune was basically clinically based. With the wake-up trial, we also have MRI-based data, which is great, and which nicely shows in the secondary analysis, if you look at the top rotor bars, that alteplase also works in lacunes, which is a good shift in favor of the patient, in favor of good outcome. And also shown in this forest plot with the stratifications that IVT works in lacunes as well as in non-lacunes, which are MRI-based, even if the study sample of patients with lacunes is a bit smaller, which leads to widening of the confidence interval. Finally, but not lastly, we look at the cerebral microbeats, did a postdoc analysis on the cerebral microbeats in IVT, which was a tiny bit smaller the group than in the whole wake-up trial, but you can nicely see that giving IVT in comparison to placebos, if CMBs are present or not, can you see the, present or not, concurs a higher risk of hemorrhagic transformation. You have a 9% higher absolute chance to have hemorrhagic transformation, but if you look at the strata, the risk does not really differ so much in patients with CMB and without CMB, and again, there was no interaction. So the CMB was not the driver to cause hemorrhagic transformation. More importantly, functional outcome. Here we looked at functional outcome. And again, you have strong evidence that IVT works with a point estimate of 1.8. And very interesting, the point estimate was even higher in those patients having CMBs. You had an 8% higher absolute chance to achieve good functional outcome at 3 months in the whole group, and it was even 14% in the CMB group. Drop of bitterness, I have to remind you that this is a group of patients with more than one CMB, so it's not a group of patients with more than 10 CMBs. So probably dose plays a role, and this is just comparing no CMB and CMB. Nevertheless, there's no interaction, so there's no evidence of a reduced treatment effect of IVT in these patients here. I also looked at perivascular spaces, couldn't find any data, so I have to ask you to wait until the data of my PhD student is ready to be shown here, but at least you can be expecting some. So I come to the end of my talk. So what are the take-home messages? As you all know, you don't want to have small vessel disease because it concurs a risk for a worse prognosis. I make a strong point that it is worth to look at the details because the impact of lacunes, white matter hyperintensity, CMBs are different in their impact. There's a strong dose response. Always remember CVD concurs a risk for ischemic and hemorrhagic stroke. Yes, small vessel disease means that ICH is more likely as compared to no small vessel disease, but still IVT is associated with a good outcome, so there's net clinical benefit. And if you look at the individual imaging markers from the data we have from the wake-up trial, MRI-based, there's no reason to believe that white matter hyperintensities, lacunes, or cerebral microbeats with a median of 2 would reduce the IVT treatment effect. Thank you very much for your attention.
Thank you, Dr. Nolte. We will take questions at the end. We move now to our third speaker, who is also my co-chair, Dr. Sheila Coots from the University of Calgary, who is also the primary investigator of Tempo 1 and Tempo 2 trials, is going to discuss about patients with low NIH.
Thank you. I'm going to talk today about the low end of the difficult decisions. This is my disclosures. The main one is that I'm running the Tempo 2 trial, and study drug is provided by Boehringer Ingelheim. So what is low NIH? And I think it's not quite as simple and straightforward as a number, and I really do think this is the art part of thrombolysis. For me, somebody coming in with an NIH of 20 who's globally aphasic, 2 hours from onset with an M1 occlusion, there's really not a lot of decision-making other than let's go as quickly as possible. And any complications, obviously you don't want them to be very high, but the decision-making doesn't really involve how high is the risk here, because you know that the outcome is almost uniformly going to be very bad. The other end of the spectrum, though, is not quite as clear. Yes, there's some chronic minor disability, but for the most part, people are not going to be incredibly dependent in a nursing home or dead. And so the treatment decision here is nuanced and really depends on who you're talking to and what they do and the whole real patient-centered discussion. So I say non-disabling, and I'm not even going to pretend that that's an easy decision to make in the acute setting standing in the emergency department. But for example, I think that the clearest example of how this is a nuanced decision is your PCA stroke, so an NIH of 2 with a field cut. How you go ahead with that patient will really depend on if they drive or not, for the most part. If you're 50 years old, you drive, you're going to go very far with that, and that may include EVT potentially in a non-guideline based way. If you're, however, 95 years old, you may well not go ahead with something depending on the rest of the story here. So that's the sort of idea, and some of the stuff is not easy, so a minor bit of neglect in the emergency department probably will do really well. Probably, and that's the difficulty here is that medicine is a real art of probabilities. And so why is this important? I mean, the issue here is just weighing up risk and benefit. We've certainly been taught do no harm, and that is a good way to practice medicine. However, there's harm about doing nothing sometimes, and that's the nuance that doesn't make this as straightforward. The reason it is even more difficult is there's very little data out there to support one way or the other what to do. And that's understandable, which was we were looking for a positive treatment, and so looking for people who are the highest risk of disability to be included in the trials made sense. So this was the pooled analysis done a few years ago now, and found there was only 10% of patients were in a 0 to 4 NIH bracket. This was the paper that pooled the data from all the thrombolysis trials and then looked at different sort of minor stroke or later time window, etc. So this analysis specifically looked at an NIH of 0 to 4, looking at 3 to 6 month Rankin versus control. So this probably sums up in a nutshell the issue with minor stroke. So it looked like there's a benefit here, so a 9.8% benefit for outstanding or excellent outcome, so an MRS of 0.1, but actually no benefit in a 0 to 2, if you looked at 0 to 2 as a good outcome here. So you were potentially saving a bunch of MRS2, but actually killing some people. And so this is not straightforward, even looking at this result here. And so PRISMS went ahead after that pooled analysis. This was Pooja Khatri's study. Was all based in the United States, randomized trial, randomizing patients to TPA versus placebo, and aspirin was given to the non-TPA patients. One of the difficulties for PRISM was that because it was US-based, patients had to be both consented and randomized under 3 hours from onset. So that means that your minor stroke, recognized a minor stroke, was taken in by ambulance usually, had a CT scan, you managed to do all the paperwork in under 3 hours from onset. And that's tough, particularly because a lot of patients with minor stroke don't call the phone immediately, they sort of wait a little bit often and there's delays. So you only needed a non-contrast CT to get in. And certainly my view that will come to here is that you shouldn't be treating stroke with just a non-contrast CT anymore, and that includes the lower end of the spectrum as well as the bigger end. Every patient should get vascular imaging here at least. Patients were randomized to TPA versus placebo. Primary outcome was a modified Rankin score of excellent Rankin, so 0.1, and that was adjusted for age, time from onset, and baseline NIH. So they enrolled 313 patients, but the trial was terminated early due to lack of recruitment. That was a financial decision by the sponsor rather than the investigators. And so I think there's a few interesting things in this slide of the presenting event characteristics. One of them is, and this was also shown in NORTEST as well, which is that if you only use a non-contrast CT for trial enrollment, you're going to get a large proportion of mimics. In this trial, there was 12% in the TPA arm and a 14% rate of mimics in the control arm. That's high. And I always say that if you give me a report card at the end of a calendar year for my treatments, if you told me that 15% of the patients I treated with thrombolysis were mimics, I probably should get a barely passing grade, I would think. I don't think that's good care, and I think we should be fast, but we should be accurate. And so for me, that includes vascular imaging, and particularly in a minor population, you need to be sure what you're treating. And so this was the overall result. Remembering that these numbers were small, they were significantly smaller than the trial was planned to be, but there was no suggestion of benefit here in terms of the primary outcome. There was definitely harm, so they did see a 3% hemorrhage rate in the TP arm. No hemorrhages in the aspirin. We would expect some hemorrhages if you continued to enroll patients here. And they did an exploratory analysis, and even if they'd gone to the end of the trial, it was unlikely there was even a 6% treatment effect here. So overall, patients with minor non-disabling acute stroke, they found that treatment with TPA did not improve functional outcome. So a more recent study that came out is Aramis, and this was a multi-center randomized probe design looking at non-inferiority of DAPT compared to TPA in patients with minor stroke, non-disabling deficits within 4.5 hours. So the main exclusion for this one was an NIH of 0 to 5, with only allowed to have a point of 1 on any of core things such as vision, language, neglect. And that was to try and get this nuanced, non-disabled presentation. Again, you didn't require a CTA or CTP to get into the study. You had to be not disabled to come in with, and this in itself is a little bit of a problem for me in terms of these patients, because we do see a lot of patients with an MRS of 2 living in their own home, the frail elderly, and in whom a minor stroke is literally the straw that breaks the camel's back. And so to exclude these patients from these trials, I think is misunderstanding the big picture here. No history of intracranial hemorrhage, and this slightly unusual thing here, which was that if you were definitively needing anticoagulation, so you came in with AFib, you couldn't be randomized in this study. So those patients were excluded. For me, I would have not done that. I would have included them and then randomized them once you're 24 hours out, or anticoagulated them at that point. But those patients were excluded. So this is a non-cardioembolic that is known about in the emergency department trial. So this is the patient flow, and they enrolled 835 patients here, and are eventually randomized only 760. There are a lot of crossovers here, and that's one of the reasons I've just shown this. 75 in this arm did not receive intervention as randomized. 60% crossed over to the DAPT. In the other arm, there was 87% crossed over to the alteplase. And so there are a little bit of issues here with crossover. And obviously that doesn't give me warm and fuzzy feelings about the overall data, but they do a sensitivity analysis looking at that. So what did they find? They were a relatively younger population compared to the large EVT trials. So median age was 64. 31% women, so again, an issue to extrapolate to outside of China, so I would like to see that closer to 50%. Median NIH of 2, so they were mild. These patients did really well, and so at 90 days in both groups, they have 93.8% in the DAPT group, and then 91.4% in the TPA group had excellent functional outcome. This met their non-inferiority margin. The other interesting thing in this study is that the hemorrhage rate was extremely low, was lower than I've seen in any trial. So the symptomatic hemorrhage rate was only 0.3% in the DAPT group and was 0.9% in the TPA group. Very, very low. And even with a very, very low, they didn't see a huge benefit in the TPA arm here. So they did do analysis looking at sensitivity, if you exclude the crossovers, etc. And certainly there's no striking change to the data when you do that. And if you look at the death rates are actually quite low here. And I think one of the things that happens with minor stroke is that often the minor stroke is the can of worms that you start opening, and you discover they've got metastatic cancer and other things going on, unfortunately. And so these rates are actually quite low. Early neurological deterioration, also quite low. So, I mean, these are fairly standard results, although I do think these patients were quite mild. So what did they, I mean, ultimately in this, that was within 4.5 hours of onset, DAPT was clearly non-inferior to TPA with regards to excellent functional outcome. So this is what we've got. For me, I would suggest that the rate of hemorrhage is probably in that 2 to 3% rate. I think Aramis is an outlier here. Everything else has certainly looked like it's more of that 2% rate. There's going to be a floor, although the risk of hemorrhage is lower in a minor population. It's never going to be zero. It's always going to be higher than the cardiac world, and so that's always there. And what that means is that personally, even if you've had one of these happen to you, it's going to take you at least 10 years to see a second one unless you're really unlucky. And so I will just say that I had, in my Tempo 2 trial, I had a patient that had an NIH of 2, was randomized to tenecteplase, had a massive hemorrhage and died. And that is a very humbling feeling as a physician, where the patient had some slurred speech and a little bit of facial weakness. Even in retrospect, there was nothing that put him at particularly high risk. And so it's one of these things where think about it carefully when you're making a decision to treat a minor stroke patient. So I just alluded to that a little bit. For me, tenecteplase and TPA, I think, are quite similar. We know from Bijoy Menon's work, published last year, that certainly in the Canadian setting, the results were very similar. We've shifted to tenecteplase as our standard of care in Alberta, in Canada, and that's true of many places, including in the United States. It's much easier to use. I don't think, though, that the results are going to be significantly different by the use of T&K versus what I've described in TPA. Just a quick aside, this is Tempo 2 we're running, so this is low dose, or stroke dose now, so 0.25 milligram per kilogram of tenecteplase against non-thrombolytic standard of care. We are still ongoing here. We've enrolled 860 patients, and these are T&K versus non-thrombolytic standard of care, mostly will be DAPT. And then, again, alluding to one of the issues of some of these studies is we do include patients with an MRS of 2, and the idea is that if you have a 2 and you go out with 2 at 90 days, then that's a good outcome. And these patients are very important for trials. So just to have a quick sidestep, so we're talking about thrombolysis. I'm also just going to say that there's no real data for EVT in a minor stroke population either. This is Nagaras Dagi's work looking at EVT patterns in Florida. And there's a 4% hemorrhage rate in a 0 to 5 population and a 5% in-hospital mortality. So clearly we need randomized trials. We don't know what to do in this population. And it's not 100% safe. So I think just to step back a little bit and just say, I think we clearly have community equipoise here. And in some ways, I mean, we're all over the map. Some centers still do aggressively treat all patients with minor stroke. I don't believe that the data supports that. I think you need to have disability, or you think there's going to be disability. I think you can use imaging as well to help you. But overall, the vast majority of minor stroke patients I wouldn't personally treat with thrombolysis. But I do think that you should be looking carefully at these patients. You need to assess them in person. I don't think you can get a good sense of disability with a minor deficit on Zoom that easily. I think that DAPT will be the case for most patients, not thrombolysis. But you need to be watching these patients like a hawk if they've got vessel occlusion and you haven't treated them. I would plea for randomization in trials like ENDO-LOW and Tempo 2, and you need imaging to confirm diagnosis here. So I'll stop there. Thank you. So we're going to finish this session with the last talk from Georges Sougoulis from Athens, and he's going to give us a talk on thrombolysis in the elderly.
Okay, thank you. I would like also to thank the organizing committee for giving me the opportunity to be part of this session. This is my intellectual and financial disclosure slide. I also have a personal disclosure. I have been treating for the past several years many patients with stroke who are older than 80, 90, and 100 years old with TPA, and I guess most of you here are doing the same. So I don't know how gray is this topic. So my job here is to first outline the scope of the problem with the increasing population of the oldest old among acute ischemic stroke patients, And I'm going to show you an overview of the safety and efficacy of intravenous thrombolysis in this specific stroke subgroup using both observational and randomized data. I'm going to discuss some specific clinical scenarios in this patient subgroup, bridging therapy versus direct mechanical thrombectomy, tenecteplase versus alteplase, the scenario of multiple cerebral microbleeds. I'm going to review the international recommendations and finish with my concluding slide. So we know that about 1/3 of acute stroke occurs in people aged over 80. There are scarce data from randomized controlled trials regarding the safety and efficacy of thrombolysis in this specific subgroup. The 3 European trials excluded patients who were older than 80. There were 42 patients in the NINDS 1 and 2 trials. And of course, the largest to date phase 3 RCT is the IST3 that has randomized more than 1,600 patients to thrombolysis, to alteplase, or placebo. So there are valid fears that advancing age may be associated with a high risk of symptomatic intracranial hemorrhage and in-hospital mortality in this specific patient subgroup. And also there is a substantial age gap between real-world evidence studies and randomized controlled clinical trials. This is nicely shown in this recent narrative review by Yannick Bezot, where you can see a substantial age gap between the mean age of the study population of randomized controlled clinical trials, shown as red circles, in comparison to observational real-world studies, shown as light blue circles. And this difference is even bigger when we calculate the median between randomized and observational studies. So the mean difference in age was 4 years between randomized and observational studies, and the median and the difference in the median age was 7 years. And there was only one randomized controlled trial with a mean age of more than 75 years, that was IST3. So it is safe to say that elderly patients are severely underrepresented in randomized controlled trials, and this age gap between real-world studies and randomized data is going to increase in the coming years. Now, moving towards the evidence with regard to the efficacy of thrombolysis in this age subgroup, I think the first major paper comes with a collaboration between SITS-ISTR registry and the VISTA collaboration. So the SITS-ISTR registry provided patients treated with thrombolysis, and the VISTA collaboration provided matched patients who were not treated with thrombolysis. And you can see here that patients who were older than 80 and who received thrombolysis had the high odds of excellent functional outcome defined as MRS 0 to 1 and a low odds of mortality during the first 3 months following stroke onset. And this effect was similar in octogenarians and nonagenarians. So this study provides solid observational evidence that age alone should not be a barrier to thrombolysis. The TRIST collaboration recently published an important analysis which included almost 1,000 patients who were older than 90 years, and it provides reassuring data regarding the safety of intravenous thrombolysis in this age group. And you can see that there is an overlap of the 95% confidence intervals, and there is no excess in symptomatic intracranial hemorrhage in nonagenarians treated with intravenous thrombolysis. And the investigators underscore that very high age itself should not be a reason to withhold intravenous thrombolysis. Similar data come from national registries, cases registry in Canada, the National Inpatient Sample Database from the US, and a big registry from Italy, underlining the safety and efficacy of thrombolysis in patients who are older than 80 years. A recent subgroup analysis from the SITS registry evaluated the safety of intravenous thrombolysis in patients who were older than 80 in 2 time windows, 0 to 3 hours and 3 to 4.5 hours. And there was a small increase, but statistically significant increase in the rates of symptomatic intracranial hemorrhage that was between 1 to 2%. However, this did not translate into worse functional outcomes, and the functional outcomes were similar. You can see the distribution of the MRS scores in the two groups in the relevant Grota bars. They're practically identical. So patients who were older than 80 years had the same functional outcome at 3 months, independent of whether they were treated within the 0 to 3 or 3 to 4.5 time window. Again, the investigators conclude that the absolute difference between the treatment groups is small, and we should not withhold intravenous thrombolysis using age as an exclusion criteria. Now, let's move to the randomized data. I think everybody is familiar with the individual patient data meta-analysis published by Emberson and colleagues in Lancet that included all available randomized clinical trial data. You can see that, again, in patients who were over 80 years, there is a significant increase in the excellent functional outcome defined by MRS 0 to 1 in patients who were treated with thrombolysis, 56% increase compared to placebo. Interestingly, there was no increase in the rates of fatal ACH, 2% in patients younger than 80, 1.7% in patients who were older than 80. And our international collaborative group used a different approach by calculating the NNTs. The NNTs are identical in the two age subgroups. When you use randomized controlled trial data, 20 whether you're below 80 or 20 whether you're above 80. Now, the Italian stroke study group conducted the TESPI trial, which was prematurely discontinued after the results of the IST trial. This trial aimed to randomize only patients who were older than 80, either to intravenous thrombolysis with alteplase or to placebo. The mean age in the two treatment groups was 85 years. And as you can see, there is a trend towards improved functional outcomes in patients treated with intravenous thrombolysis. Of course, this is not significant. However, there was no difference in the rates of symptomatic intracranial hemorrhage between the two groups. The absolute difference was only 0.8% increase with intravenous thrombolysis. So the investigators repeated the meta-analysis conducted by Emberson, and after also adding their data. And again, we see that there is an increase in the odds of functional independence, defined as MRS 0 to 2, by 50% with intravenous thrombolysis. There is a non-significant decrease in mortality, and of course, there is a 5-fold increase in the risk of symptomatic intracranial bleeding compared to placebo. Now, Ken Liss and Werner Hake conducted another analysis, pooling both randomized and observational data from the SITS Utmost registry, and they provide solid, both randomized and observational evidence in favor of treating elderly patients with intravenous thrombolysis. And overall, there was a positive benefit-risk profile in patients above 80 years old. First of all, you see that there is no evidence of interaction between age and the efficacy of intravenous thrombolysis compared to placebo. And then there is an increase by 6% in the absolute rate of excellent functional outcome in patients treated with intravenous thrombolysis compared to placebo. And this is only strictly randomized data. And there is a non-significant decrease of 0.7% in the mortality. Now, let's move to the question of whether we may consider treating older patients with a lower dose of TPA. This is a post-hoc analysis from Enchanted trial, where patients were randomized to either 0.6 or 0.9 dose of alteplase. As you can see, again, there is no evidence of interaction on the efficacy of intravenous thrombolysis, high dose, standard dose versus low dose. Interestingly, if you see the direction of the effect size, it favors standard dose of TPA. Now, with regard to different definitions of symptomatic intracranial hemorrhage, there is no increase with the high dose compared to the low dose in patients over 80 years old, independent of the applied definition, either SITS-MOST, NINDS, ICAS-2, ICAS-3, IST-3, and fatal hemorrhages. So again, this is reassuring data that we should be treating elderly patients using the standard 0.9 milligram per kilogram alteplase dose. Another clinically relevant question is whether we should be withholding intravenous thrombolysis in patients with large vessel occlusion who are over 80 years old, and maybe these patients should be directly transferred to the angio suite to receive direct mechanical thrombectomy. I think the recent individual patient data meta-analysis from IRIS collaborations provides solid data to answer this question. There were 2,303 LVO patients who were included in this analysis. Approximately 500 were above 80 years old. And as you can see, again, no evidence of interaction between age and the efficacy of bridging therapy compared to direct mechanical thrombectomy. Again, if we notice the direction of the effect size, it favors intravenous thrombolysis plus endovascular treatment. And in the supplement, there is available data from 5 out of 6 trials. And it's very interesting that in the 2 trials that were conducted mainly in Europe, Swift Direct and Mr. Clean No IV, bridging therapy was superior to direct mechanical thrombectomy in the age group of patients who were 80 years or older. So again, reassuring data about treating these patients with intravenous thrombolysis. The third clinical scenario is whether we should be treating these patients with alteplase or tenecteplase. We know that currently there is a label for alteplase only. However, we have 2 phase 3 trials proving the non-inferiority of tenecteplase compared to alteplase. The first one was conducted in Canada. It was Acute trial. It randomized 1,600 patients. More than 500 patients were aged 80 years old or older. Again, no evidence of interaction between the treatment effect of tenecteplase compared to alteplase with relation to age. This is data from Acute trial. And then this is the phase 2, phase 3 randomized control trial, which was conducted in China, that has randomized more than 1,400 patients. 137 were above 80 years of age. Again, no evidence of interaction between age and the comparative efficacy of tenecteplase versus alteplase in this specific stroke subgroup. The fourth question is related to the high cerebral microbleed burden. The second speaker, Dr. Norte, also referred to this topic. This is a meta-analysis that we have conducted, and we know that the presence of at least one cerebral microbleed increases by 2-fold the risk of symptomatic intracranial hemorrhage, but this is a very small increase in terms of absolute numbers. However, more than 10 cerebral microbleeds increases by 12-fold the risk of symptomatic intracranial bleeding. And although this patient subgroup is small, 0.8% of the patients who were included in the meta-analysis, the absolute risk of symptomatic intracranial bleeding is high, approximately 47%. So this is a group that we need to be aware of and perhaps withhold thrombolysis. This was also our experience at the University of Tennessee before this publication. This is a patient with multiple cerebral microbleeds in the occipital lobe. This was his MRI before coming to the IR with stroke symptoms. He was treated with TPA, and you can see multiple remote cerebral microbleeds. And I would like to caution our audience that the incidence rates of cerebral microbleeds increases exponentially with increasing age, and this is irrelevant of the pre-existence of previous microbleeds or not. So the Charité group, led by Christian Nolte and Matthias Endres, developed an elegant multi-step algorithm to model 90-day functional outcomes in patients with and without high cerebral microbleed burden who received and did not receive intravenous thrombolysis. They provide evidence that high cerebral microbleed burden modifies the treatment effect of alteplase, especially in older patients with severe strokes and longer treatment delays. However, they also highlight the fact that the general pretest probability of more than 10 cerebral microbleeds is low, ranging between 0.6 and 2.7%. So we should not be requesting pre-treatment MRI from our patients, only in the clinical scenario that this will not delay TPA bolus by more than 10 minutes. So if we can do that and there is a delay of less than 10 minutes, then this is a good idea. And I would like to highlight this analysis in patients who were over 80 and had a 9-night stroke scale score of 15 or greater. This is the net benefit. You see there is no evidence of net benefit independent of the onset to treatment time. So I think this is a group that we may caution against using intravenous thrombolysis. Having said that, this is a patient who came at our center in Athens. He was cognitively impaired, and he had a mild right hemiparesis. We did a pre-treatment MRI, and with all these microbleeds, we decided not to treat this patient with intravenous thrombolysis. Moving now to the end of my lecture, I would like to summarize the available international recommendations. These are the European Stroke Organization guidelines on intravenous thrombolysis. This was the writing group. High quality of evidence, strong recommendation to treat patients over 80 with intravenous thrombolysis within the 4.5-hour window. Unanimous expert consensus statement that highlights that age should not be a limiting factor for intravenous thrombolysis in other situations covered in the present guidelines, for instance, wake-up stroke, minor stroke with disabling symptoms, and the extended time window between 4.5 and 9 hours using perfusion mismatch. With regard to cerebral microbleeds, if they're less than 10, then the recommendation is to treat with intravenous thrombolysis. If there are more than 10, there is low quality of evidence and a weak recommendation to withhold intravenous thrombolysis. However, there is a unanimous expert consensus statement that we don't need systematic screening with MRI to assess cerebral microbleed burden. Now, the American Heart Association recommendations are similar, not identical. They provide a class 1 level of evidence A recommendation for treating intravenous thrombolysis within the 3-hour window. However, the class of recommendation goes down to 2A and the level of evidence to be non-randomized for the time window between 3 and 4.5 hours. And again, they highlight the fact that caution is needed in patients with a high cerebral microbleed burden exceeding 10 microbleeds, and treatment can be reasonable if there was a potential for substantial benefit. Class of evidence to B. Now, is there any difference between the two labels in Europe and North America? Yes, there is. There are two important exclusion criteria in the European label: age over 80 and a 9 stroke scale score above 25. Fortunately, the European label has been modified and the age limiting criterion has been removed, and I quote that Actilis can be used in patients over 80 years on an individual benefit risk basis. So the label has changed in Europe, and here is all the data that I have shared with you using randomized trials and observational evidence to highlight the decision of the change in the label. So coming now to the end of my lecture, I would like to stress the fact that elderly patients are severely underrepresented in randomized controlled trials of intravenous thrombolysis, and there is a substantial age gap between real-world evidence studies and randomized trials. Patients who are over 80 years is the fastest growing stroke subgroup. These are actually our fathers, our mothers. IVT is the only effective systemic therapy that may reverse neurological dysfunction and improve functional outcome. I believe that I have shown you data that can convince you that it is safe and effective to use in elderly patients. We should be using the full dose alteplase. I think that bridging therapy is safe in these patients, except if they have other contraindications for intravenous thrombolysis, where in this case we can move directly to the angio suite. Tenecteplase is non-inferior to alteplase in the elderly, and I believe it may not be safe in this specific age subgroup to give TPA if there is pre-treat MRI with high cerebral microbleed burden, more than 10 microbleeds, and especially in the scenario where we have a severe ischemic stroke with an NIH of more than 15. So just to summarize everything, I will just use the Nike logo. Just do it when an elderly patient comes to the ER. Do not look at the age. Think him of as your father, your mother, your aunt, your uncle. Just give TPA. Thank you.
Okay, we're just going to ask the rest of the speakers to come and join us up here, and we're going to take some questions both online, if you want to enter them online, or we will take questions from the mic as well. I think we'll start with one from the audience, and then we'll go ahead with the online. Go ahead.
Yeah. Hi. Good morning, everybody. This is Cyrus Katsanos from Hamilton. Great presentations. A question to all four of you. So, testing for non-inferiority is totally appropriate in the right setting. The question is that if you're expecting marginal benefit, and especially if you're stepping down on therapy, whether it is appropriate to do so. And I'll make myself clear. So I'm going to George's presentation. So if you run a trial testing non-inferiority on TPA on octogenarians or people with disability, MRS 4 or 5, it's not hard to prove non-inferiority, especially if your margins are kind of generous, right? So that's the one thing. And the other thing is that, it took us for decades to convince neurologists to get out of the bed and not to be afraid of bleeds. So my worry is that we're taking some steps back, and also the generalizability of those findings, because not all the patients have access to stroke experts. So there is a good chance that some of the patients may get undertreated if we don't be cautious about it. Thank you.
I think that was a general comment made by Aristides. I don't know if anybody...
I have nothing to add. It's very important to define the non-inferiority margin, because you can prove non-inferiority if you set your goals as they are. A very important question.
There is a question submitted to the app by Hanne Christensen from Denmark. The question is related to Dr. Meinel's talk. She thinks that you're too conservative as to IVT and factor 11 inhibitors. The theoretical risk is low, and a few patients treated with IVT in Pacific, and the general bleeding risk was very low.
Yeah, thank you for the question. Is this on? Yeah, okay. So maybe I've been too long in Switzerland, so I was saying between the lines that maybe we should not repeat the same mistake that we did for DOACs and put them as an absolute contraindication. I was saying if we follow the cardiology guidance, maybe we say there might be some increased risk, but we should not put factor 11 inhibitors again as an absolute contraindication and then try to overcome this contraindication. So I agree that factor 11 inhibitors, the bleeding risk is very low, and probably also with IVT this needs to be shown, but I think we should not exclude all those patients from IVT by putting it again as an absolute contraindication. Fully agree.
A question from Dr. Selinger.
Question for Sheila. Great talk. I only have an issue with the role of double antiplatelet therapy, also in comparison to fibrinolytics. With regard to the bleeding risk, at least in point, there was a significant increase in symptomatic bleedings with worse outcomes, whereas DUBT only prevented non-disabling stroke recurrence. And Aramis, if I recall it correctly, is the only trial that ever tested that with all the drawbacks that you pointed out. Could you again comment on that? Are there other trials directly comparing fibrinolytics with DUBT?
I'm not aware of any other trials. There probably are some, but I'm not aware of some, Peter. I agree that there was differences in chance and point in terms of the outcomes. Chance didn't see an increased risk of bleeding, and point did, and it is a little bit of a balance in the same way that it is with thrombolysis. So I I don't know that we know the clear answer. The answer is not that all of these patients should be thrombolized. I think it's a nuanced patient in front of you decision that's not easy, as I've alluded to. I think there's more studies need done for sure, but we need more academic rigor because people need to, meaning me and everybody at this table, needs to randomize patients and not just think they know what to do, because we don't.
There is a second question to Dr. Meinel by Dr. Chen. Any comment on the rapid urine analysis of DOAC plasma level by the German group before IVT?
So the question is about urine dipsticks. As you know, urine dipsticks, they can be used as a replacement for plasma level measurements and may be more easily obtainable. The problems I see there is first, to obtain urine in the emergency setting, you need to place a cath. Second, even with the gold standard of plasma levels, we don't see any correlation with bleeding events, and there is a constant debate about the right cutoffs. The currently in place urine dipsticks, they are very sensitive, so they will pick up basically any DOAC concentration. And we know that in this DOAC concentration in the plasma level between 30 and 100, probably bleeding risk is very low. So you will exclude a lot of patients based if the dipstick is positive. You will cause some delays by placing the cath until you have the result. And my opinion is that for ischemic stroke, we don't need it to select patients for IVT. This is how we practice it at our center. However, there might be other indications. Maybe you think about reversal for ICH, where you need to know is there any DOAC on board, where maybe those tests are potentially helpful in a setting where we cannot get DOAC levels easily and quickly.
Then there is a question to Dr. Nolte. Is there any consensus as to workup incidentally found lesions on MR done for non-stroke symptoms that are not specific? This is from Dr. Al-Halabi.
Sorry, I didn't get the question right.
Is there any consensus as to workup of incidentally found lesions on MR done for non-stroke symptoms that are not specific?
That's a very nice question. So, is there a consensus on how to work up incidental findings? I don't think there's a published consensus, and I think it's a very urgent matter to take care of. I'm personally of the opinion that if we know there has been a stroke, we should check it up and make sure that we place adequate secondary prevention, even if it's not clinically present or without clinical signs or symptoms.
Then there is another question directed to me by Dr. Desai. Would you wait on an MRI for a patient older than 80 years to rule out cerebral microbleeds, or just take the unknown risk and offer IVTP or TNK if this patient has no LVO? I think I was clear on my presentation that we should move and treat these patients and not wait for an MR, and pretest probability is low. In our own meta-analysis, it was 0.8%. In the work by Christian Nolte and colleagues, it ranged between 0.6 and 2.7%. I think, is that gets to Mala? That is, yeah, gets.
Yeah, thanks a lot. I have a question regarding TNK, so maybe to Sheila, because you mentioned this, but maybe also to all of you. It's interesting, you said you have shifted to using TNK instead of alteplase, and a lot of centers worldwide are doing this. I think we are still a little bit far away from this in Central Europe, but we have a lot of data on alteplase, and we heard a lot about the gray zones, like a minor stroke or elderly patients. Do you think we have to repeat all this for TNK, where the database is much slower? Can we simply transfer these results to the use of TNK?
No, I don't personally think we need to repeat everything that's been done. I think the data, well, the data so far from Act Quicker, from Bijoy, certainly looks that it's very similar. We will get data from a test 2 this week that will also add to that. So I don't think that we need to repeat everything that's been done. There's still clearly questions, as we've already shown with these talks today. So I think we need to just keep going and not repeat, but continue to get more data.
Then there is another question for you, Sheila, by Dr. Abdel Malik. Question regarding not treating the low non-disabled cases. Does threat of clinical worsening later at a time outside the window, or CTA demonstrating LVO sway your decision at all?
Yes, I use imaging to help me decide what to do, and I think the important thing is that everything here with thrombolysis is a balancing act between risk and benefit. So yes, I will do a CT, CTA, sometimes a CTP. I will look at what I think the risk of that patient deteriorating functionally. And yes, at a time window that's late, what I normally do is we have the Tempo 2 trial running. We would randomize the patient in the trial, and whatever arm they were randomized to, they would be admitted, they'd be watched very carefully in an acute neuro unit on IV fluids, kept flat for the first 24 hours, even in the control arm, and that's certainly what we've been doing. So I do use the imaging, and sometimes it may be the thing that pushes you to treat if the patient was borderline disabling to begin with. So everything is an accumulation of information, not just one thing.
Okay, next question by the gentleman on the microphone. I'm sorry, I'm blinded, so I cannot easily identify.
Yeah, Wayne Sunman from Nottingham, UK. The IST3 study was a very good study, but it excluded anybody who was disabled at all. So when you come to analyse the elderly, you're probably getting a fit elderly population. Is there data on what to do with people who are frail elderly who are already disabled? There was some reference to people having MRS2.
No, there's not good data out there, and I think it is important. And it's not just the minor strokes, EVT, there's lots of question about what to do with the previously disabled. I know that when we ran Tempo 1, we did exclude the MRS of 2, and that was an issue. We had a lot of patients coming in who were in their own home but had an MRS of 2 that we couldn't include in the trial. And so the plea is to include patients in trial. Inclusion criteria should be relatively inclusive of the population we see, and that includes not excluding the elderly as well.
Thank you.
There is some data from SITS registry that has included patients with MRS 2, 3, 4, and 5, and they basically showed that in a substantial proportion of these patients, the MRS did not change after receiving intravenous thrombolysis, and this is what you want to offer in this patient. If there is an MRS of 3, then you want him or her to stay at the MRS of 3. So there is this post hoc analysis of observational data from SITS registry. Then there is a question that is addressed to Christian and myself. Do you consider extensive leukoareosis on brain CT as a contraindication for intravenous thrombolysis in elderly patients because of the high risk of symptomatic intracranial hemorrhage? Christian, you can start.
Well, I think the point that has to be made is that it's not monodimensional, isn't it? I mean, cerebral microbleeds, cortical cirrhosis, severe white matter hyperintensity, they're all parts of the picture. So if you have a 90-year-old who lives in a nursing home, has 9 microbleeds, has cortical cirrhosis, has severe white matter hyperintensity, you might choose to not thrombolyze them, and you're free to feel so. The point I think we wanted to make is that it's not the single sign that rules out the indication. It's not just age, or not just cerebral microbleeds, or not just white matter hyperentensities, because if you look at the single aspects, the data supports to use IVT in most cases. You would probably agree that even the number of 10 is artificially. You could have chosen in your analysis 12, or you could have chosen 8, and you choose 10 because we have 10 fingers, and because 10 is just in our heads. So you always have to look at the whole picture and make your decision with all these different aspects, and all these different aspects make the whole picture. That would be my answer.
Yeah. I would not be concerned by extensive leukoareosis on an elderly patient, especially if there was no history of dementia, and I would move forward with intravenous thrombolysis in this patient. Now, if there are also, as you mentioned, other factors like multiple microbleeds, like history of dementia, then this might change actually my treatment decision. And then I think there is the final question. No, there are another two questions. One is addressed to Sheila. Cortical non-lucky strokes usually progress over the first 1 to 4 hours, often with a misleadingly low NIH. Therefore, isn't there a risk of not treating such cases with IVT ASAP? The trial outcomes should be based on comparing both these groups. By Dr. Shah.
I agree. I think that in some ways the lacunar stroke is the last bastion of stroke care that we really don't have a good treatment for acutely. I think it's difficult, and personally, if somebody is completely resolved, I'll just reset the clock, and I have thrombolyzed people 24 hours into their symptoms who've been fluctuating. It's a difficult group, and again, that's just at the moment we don't have a good way of identifying who's going to deteriorate.
Then there are last two questions addressed to me. Well, the first one, is there any sex difference of AIDS patients in response to intravenous TPA? No, there is not. And there was no sex interaction, neither age interaction in any of the randomized trial that I shared with you. I didn't go over the sex interaction, but there is no evidence of that. And then, do you consider amyloid angiopathy contraindication to intravenous thrombolysis? So, according to the Boston criteria, you need to have like macro bleeds, not only micro bleeds, for cerebral amyloid angiopathy, or you need to have transient focal neurological episodes coupled with cortical superficial siderosis that this is disseminated. So in clinical practice, I need to see the MR of the patient in order to decide if this is a contraindication. Obviously, if there are macro hemorrhages, then this is a contraindication. And then, especially for patients with a history of cerebral amyloid angiopathy, then we need to be very, very careful with transient focal neurological episodes that can be mistaken for acute ischemic stroke symptoms, and we should not treat these patients because the consequences will be devastating.
I think that's that we're going to conclude the session, and thank you for all your interaction.